Welcome to LifeFWD, a webinar for advisors. Before we begin, I'm incredibly excited to share with you some recent news. You told us pricing matters, and we listened. BMO Insurance has recently updated our term pricing to stay competitive. Today, we are the most competitive priced term insurance in the market across all age bands and all face amounts. Now you can engage with your clients with confidence, reopen conversations, and deliver value where it counts. Beyond pricing, BMO Insurance remains focused on strong and dependable service, and this is how.
At BMO Insurance, customer experience is a promise we back with clear, measurable service level agreements. In the last year, our teams supporting you have driven real results. Now, progress sets the pace. Smart app submissions reach underwriting within 1 day of submission, and 99% processed within our service level agreements. Policy settlement within 2 days, and claims completed within 10 days. We know time is valuable. That's why our new business team routinely answers phone calls within 1 minute and provides email responses within 24 hours. Because when SLAs deliver, your business accelerates. We've redefined what fast and reliable service looks like, empowering advisors with the tools to drive business forward. Service level agreements aren't just targets, they're a commitment to our advisors. And at BMO Insurance, we're raising the standard.
Heart disease remains the #1 cause of death in North America, affecting more people each year despite advances in medicine and awareness. On this episode, Katarina Nikolic, Vice President and Chief Corporate Underwriter, and Dr. David Alter, cardiologist at Milton Cardiac Care, will discuss why this disease continues to be so prevalent and what can be done to improve heart health. Over to you, Katarina.
Thank you for joining us today, Dr. Alter. Today we want to cover a topic that I think is really important for a lot of Canadians, and we talk about heart disease and its importance both on longevity as well as prevention.
Great to be here. I'm looking forward to having the discussion.
So maybe we could start and talk a little bit about cardiac disease. I mean, I know in underwriting, that can be a big umbrella of different things. It could be arrhythmias, cardiomyopathy, structural heart disease, etc. But I think for the purpose of today's discussion, I think we maybe will talk about something that's a little more familiar for people, which is atherosclerosis and cardiovascular disease. And maybe what you and I can try and do is be less technical from an underwriting perspective or even from a clinical medicine perspective and talk about plain language and maybe looking at things that can really help people with risk mitigation strategies and prevention. I know that one of the things that perplexes me all the time when we think about cardiovascular disease is why is it that it's still the #1 killer, not just in North America, but around the world? For those that, in the audience that don't know what it is, we're really talking about those fatty deposits of cholesterol and plaque that build up in the arteries. And I think those can occur in different places. That could be maybe in the neck, in the abdomen, the legs, the kidneys, and then ultimately in the heart. And then people recognize that as heart attacks. And so when we think about things like cancer, we may not know the cause, but we do know the cause of coronary artery disease. And when you know the cause, I think it means it's more modifiable and modifiable risk factors that can then lead into prevention. So give me your thoughts on prevention in cardiac disease and what we're seeing today.
Great question. So cardiac prevention, so heart disease and atherosclerosis is a disease of aging. So I'm going to reframe your question a little bit. How do we think about the prevention of aging and why is that important? Because that eventually 97% of us will have atherosclerosis or blockages in our arteries at some point in time in age. So the answer is, how do we prevent aging? Well, we can't prevent aging. What we can do is prevent the complications of aging. And as it relates to heart disease and blockages, what we're really trying to prevent are heart attacks, strokes, and premature death. Those are the complications of aging of our vessels, as you've described. And so the problem is that as a society, we don't really do a really good job of it. The good news is that if we did, upwards of 80% of these complications of heart disease can be prevented. And so why is it so important? We're an aging population. If we can prevent the complications and extend healthy aging and a healthy heart, despite blockages, then we've done a good thing.
And when we talk about some of what I call the ugly five, which are, high blood pressure, high cholesterol, obesity, smoking, these are within our control, but we also have risk factors that are out of our control. And those may be things such as family history. So, and when I talk about family history, I'm talking about premature onset and death. So, under the age of maybe 50 or 55. And there are biomarkers and tests that can be done, whether we're talking about apolipoprotein B, for example, and we can explore that a little bit later on. But I think for the purpose of diagnosis and treatment of an individual, I think a lot of those things that you've just touched on really have an impact and pay in dividends when it comes to looking at prevention and aging in the cardiac space. In underwriting, I know one of the things that we look at is not just the diagnosis of the individual that's presented to us, but what are some of the risk factors that impact the risk trajectories that people take. So we know that habits have a direct impact on someone's longevity, and particularly someone who's been diagnosed with coronary artery disease and atherosclerosis. And so when we think about poor diet, someone who may be consuming a lot of saturated fats or trans fats, a lot of high processed foods and sodium, I think that has a big impact on inflammation as well as insulin resistance in the body. So I think small steps make a big impact. We do know that there's a direct correlation between sodium and high blood pressure. I think smoking as well, and smoking that includes vaping, to me is almost like putting the glue into someone's coronary artery disease. It has a direct damage to the endothelium itself and can cause clotting and so forth. We also look at stress and cortisol spikes and how that affects the sympathetic nervous system. I would say, I would like your opinion maybe on what do you think about obesity? And because there's some controversy there. There's BMI, but there's also people's body mass. And so when it comes to visceral fat, so those people that carry, maybe a little bit more around their waist and they may be a little skinnier, but yet they're dying from heart attacks. So I think probably less so about the weight itself, but more about the body composition. What are your thoughts there?
Well, you're right. Our measures of kind of body mass index, these are really good at the population level, but at an individual level, I was always, the best example is Arnold Schwarzenegger, who had a huge body mass, but, obviously it encompasses muscle. And so it's not a great measure. It's not like abdominal obesity or adiposity. It's the distribution of fat that is toxic and metabolically toxic that we think about. I feel, we've come a long way in treatments like GLP-1 agonists and things like that. But I feel like our society is still very much quick fix and looking for the quick fix drugs. And when I see patients who are, on the Ozempic, but are not adhering to the other aspects of lifestyle, like exercise, and appropriate, balanced diets. I don't think that's what the intent was.
Yeah. And there's been a real rise in GLP-1 drugs. And I know in underwriting, we look at those now quite favorably because there's a lot of protective value, whether it's for strokes or for peripheral vascular disease or other types of diabetes, which is what it was originally designed for. But how do you feel about maybe those individuals who go on it and don't make those modifiable risk factors, and then they're constantly needing a renewal of prescription on a regular basis?
I think that the evidence in terms of its benefits were mostly shown among those people who were also exercising and doing all of the right things. And so I actually have these conversations all the time with my patients. This is not a replacement for exercise and doing the hard things sometimes. The other thing that people don't realize until they've been on it is really you lose so much muscle mass and there's side effects to these medications. When you come off of these medications or can't tolerate it, weight climbs. This is not a forever thing. And when people are on these medicines and are not exercising, they lose muscle mass.
And we know muscle mass is critical for longevity, and we
Critical.
know, yeah.
Absolutely critical. So I think coming back to the central premise, I think we've got these great tools and these great medications, and they serve us well in certain circumstances, but they are not a replacement for exercise and for appropriate lifestyle. I think people are trying to use them too liberally, and that's my concern.
Agreed. And I'm sure without getting into a conversation of how much this is prescribed in the US and versus Canada, that's a whole other ball game. And so when we think about sleep as well, I know we talk about sleep in the context of longevity, but sleep is really important when it comes to cardiac disease as well. And so I oftentimes think about sleep in the context of cardiac diseases, less than 6 hours, and or people who have untreated sleep apnea and are not using their CPAP machines. And I think that troubles both for arrhythmias as well as atherosclerosis. And I don't know if you see that in your practice.
Yeah, I mean, sleep disturbances have a lot of side effects that I see. People carry with them not only sort of the things that you've mentioned and their stress, and often sleep deprivation or bad sleep is also a manifestation of their other lifestyle. There's other reasons for that. So, I mean, sleep medicine and sleep disturbance is a whole sort of sidebar to what we're talking about. There are conditions, though, in which sleep abnormalities can kind of worsen the risks. And you mentioned one of them. So sleep apnea is one of them. Sleep apnea, undiagnosed, can cause hypertension, high blood pressure. And we also know, as you said, from people with heart disease, that untreated sleep apnea can be, a bad signal in terms of how well they fare. I look at lifestyle holistically, and sometimes, sleep is a cause of how we feel badly. And sometimes it's a consequence. It's because we're not taking care of ourselves properly that we have those abnormal sleep patterns. So comes back to really understanding sleep within the context of not only the disease, as you've said, sleep apnea and things like that, but sleep in sort of a holistic mindset of, well, are you exercising? Are you getting your appropriate diet? What other things are you doing to improve your health? That's the way I look at sleep.
And I think we can't out-medicate a bad lifestyle, but I think with a good one, we can prevent the disease.
Yes. I talk a lot about medical prevention. That's the way I look at prevention. I look at prevention, and particularly exercise, as we'll get into, as a medicine. And I think we need to adjust our mindset a little bit to the fact that, yes, lifestyle is a medicine. We have to think about it. There's a dose, there's a frequency to exercise, there's a dose to exercise, and other lifestyle factors. And I think we need to get our minds away from, lifestyle is just, having fun. And when you're in your 20s, you do it to look good or whatever. But there is a medical aspect to lifestyle prevention in the context that you're talking about. I agree 100%.
I mean, there's a lot of talk recently about, we know plaque starts forming from birth, right, in childhood, and it takes decades to actually develop plaque burden that's significant enough. And so they're talking about testing younger people more and more for the purpose of early intervention and actually taking charge of that atherosclerosis earlier on. How do you feel about that?
Yeah. So you're right. So atherosclerosis, this disease of the vessels, the aging of the vessels, begin very much earlier than we think. There's the fatty streak in our 20s and 30s. There's plaques in our 40s and 50s. There's blockages in our 50s and 60s. The earlier we can understand that, the more we can take action for it. The other thing I'll say about screening, and it's really about screening of our risk, of how our vessels are aging. That's what atherosclerosis is partly about. And some of our treatments, for example, statins, are not necessarily just tied to what the cholesterol levels are. It's what the risk level is. We understand it with a car, right? We understand these analogies with the car. We get a battery light that comes on, an indicator light, a sound. We take it to the mechanic so that we can do something about it. But something invisible about atherosclerosis, we don't really understand it as much. So I do agree.
Yeah, I mean, the car analogy, when I think of a tunnel, it's not how many cars are going in the tunnel, it's how fast they're going. And when I think about diagnostic tests, if we go on that same theme, I feel that there's a big disparity between Canada and the US. And so here in Canada, under our system, we tend to really treat people when an event happens or when they have symptoms or when they present with a really poor family history. And maybe for the audience to know what some of the basics are, from like the bottom ground benchmark test all the way up to the gold standard. And I think for in Canada, we normally start with like a resting ECG, which you're sitting supine. You've got electrodes on your chest and your legs, and we're measuring out the cardio electrical activity. And we have some signals around whether there's coronary disease or structural disease. And then we graduate to a stress ECG, which is similar, but you're running and you're seeing what the cardiac output is. And then we can layer that on with an echo and so forth. But then we get into thallium scans, which are with the dye, and you can see if there's wall motion abnormalities and any other things going on in the heart. And then finally in Canada, I think at that point we go to the angiography, where someone like yourself would actually go in and visualize the arteries. But I think there's a space in between there that's about prevention. And I don't know if this is controversial or how you feel about it, but, we talk about coronary calcium scans. And so, for those in the audience that don't know what those are, it's, in simple terms, you're going into a machine that's similar to a CT scan or an MRI, and it's taking multiple different slices and images of your heart, and it's showing within those arteries the level of plaque burden you have translated into a score. And so what do you do when a patient brings you this test result and you're trying to determine, is it soft plaque? Is it hard plaque? Is this normal for their age? Is it not normal for their age? I think there's a variance of early detection and then material pathology. So tell me what you think about them and, what your honest view is.
Yeah, great question. Reminds me of the 21 points inspection, where you take your car, back to the car analogy, and you get this report and all the things that are going wrong with your car. And at the end of the day, it says more preventive maintenance. And I get patients, often going to clinics that have, enormous number of testing, that, red marks, green marks, they don't know what it means. And at the end of the day, the message is be attentive to your health, do more lifestyle, do more exercise, may consider those things. So it's a double-edged sword. There is definitely emerging technologies that are very useful for certain people, and CT scans looking at coronary plaque are important for certain people. But as a screen for prevention, we can get 85% of it right. 85% of our risk we can calculate or estimate right through simple questionnaires called a health risk assessment that use
Tell me a little bit more about that.
Sure. Health risk assessments, they're all around, different types, often publicly available. They ask your age, sex, blood pressure, cholesterol, diabetes, smoking history, family history, very simple. And they project out your 10-year risk. And, they're not 100% accurate, but they can get us into the game of properly taking action, which is what this is all about. How do we get ourselves to take action?
Yes. We've changed now from just looking at the disease. Like if I give you an example, like if we had someone who had, one stent put into a single artery and was put on statins and changed their lifestyle and started exercising and wasn't sedentary, that risk paradigm has changed significantly. What once used to be a decline or a postpone to see how somebody's doing, we're now able to insure them, and sometimes even with a minor rating or close to standard. Of course, we're talking about single vessel disease, but, in the absence of any other risk factors. So I think that, things have changed as we look at diagnostic tests and the habits that people adopt. Underwriters are looking very closely at those habits, because two people can present on paper with the exact same cath report, but it really depends on what do they do. And I think that's what you were trying to say when we're talking about prevention and lifestyle and risk factors. We look at those in order to favor the decision.
And you said something earlier as it relates to, okay, what are we trying to really prevent? And I want to come back to this point because there is a misconception. We talked about, we use these buzzwords, atherosclerosis, blockages, plaque, aging. What do they all mean? And it's interesting. There is a bit of a disconnect in a lot of patients' minds that we can talk about risk. We can talk about, atherosclerosis and hardening of the arteries. You got blockages. What? How do I have blockages? People don't understand, it's really not the blockages that we're trying to prevent. And I want to make this point because it comes to treatment. It's the inflammation, and you referred to it before, within these plaques. One of the myths here is that plaques just grow into blockages and grow. It's not that. It's what we're trying to. Blockages are like little pustules, little pusses that can become very inflamed. Sorry, I didn't want to get too descriptive, but it can become inflamed and then rupture.
Right.
And it's a clot on top of that. So it's an inflammation process we're trying
That's
to
right.
do. So coming back to the treatments, like the treatments of everything you're talking about here, whether it be exercise, whether it be diet, whether it be statins or whatever it is needed, is working at that plaque level to suppress the level of inflammation. So again, looking for blockages and how you're assessing risk and how I assess risk, there may be different markers for sure, and more diagnosing might be required in certain people. However, the remedy at the end of the day is the same. How do we prevent these plaques from suddenly rupturing?
I wanted to ask you a question because we face this in underwriting a lot, particularly in the high net worth market, where clients are, having stress ECGs done at every corner. And then they come to the insurance company and they didn't know they had a problem, right? So the stress ECG comes back and there may be some, poor R wave progression suggesting they may have had an MI in the past. And then we have to postpone them. And so then we send them off to yourselves. And when you look at them and you do a thallium or perfusion scan, they end up coming back normal. And so they're false positive. And we spent a lot of time and we've, upset our customer. And yet, we're really trying to understand what is the value and the sensitivity of some of these tests in a clinical context.
What a great question. So here's the deal. These testing, with stress testing and perfusion testing are really good for people who have symptoms. And we're trying to sort out, are their symptoms because of their heart, or is it because of something else? And for symptoms because of their heart, the blockages do have to be big for it to be symptomatic. But here's the kicker. There can be false positives. So often we're digging ourselves out of, how do we disprove the false positive? But they're also useless very much for finding small plaque, which is what this conversation is about.
And that's why in the insurance space, a number of us as carriers have removed them as what we call age and amount requirements, meaning, we're not getting them on every single person in the general population because we know that they're not adding the same amount of value as in the past. Maybe we can pivot a little bit and talk about some of these newer tests that are out there. I know we talked a little bit about family history and the uncontrollable risk factors that associate with that. But if we think about like apolipoprotein B, and for those in the audience, again, we're trying to use as much plain language as possible. These are the bad cholesterol that's floating around in your blood. And specifically, they're kind of a good prognostic indicator when you're looking at LDL, especially if the LDL is normal. So what do you think about apolipoprotein B as a test that might be used for individuals who have that profile?
So we're really, in my opinion, we're in this really interesting evolution of evidence. We're in an evolution of evidence that have these really important biomarkers like apolipoprotein B, lipoprotein little a, things that are markers of higher risk. And we're trying to help determine how we should introduce therapy based on those markers, like statins. And so, they're really good in helping us, and we got guidelines and we're trying to be very precise. I think the challenge yet is that we're still in a medical point of view, in a medical society point of view, we're still very dogmatic. If you've got this, treat. If you don't have this marker, don't treat. When in fact, risk, like age, is a continuum. And so even though you don't meet the standards today based on guidelines, tomorrow or next week or next year or 5 years, you might. I would like to see the medical community and society move from these really important markers, which can help for sure, and I use them all the time, so I don't want to, but I really like our mindset to really shift. Okay, what is gray hair look like in the arteries? We understand it here. What does the aging skin look like? And how do because I know I'm going to get there.
Yes.
So I think we need to get more in terms of a continuum of risk, not dogmatic, you got this, you should treat. Because people go away with that thinking and think, I'm good. When in fact, that's the wrong message.
Yeah, and when we think about the future of preventative medicine in the space of cardiology, I think it's about prevention, but it's also about early diagnosis and more personalized care, right? I mean, we treat here event-based cardiology and cardiac events. I think I'd like to see us get to a point where we're taking early intervention decades earlier to be able to actually help people along the way. And so when we look about all of these tests, there might be opportunities there where we can make some inway.
Yes. And at the end of the day, tests are only good if we take action. And the earlier we take action, the better our habits will be formed. And as we age and as our risk increases, just like a car, we have to do more preventative maintenance than less. We have to put the platinum fuel in as opposed to the bronze or whatever that is. The earlier we develop the habits and the understanding that risk can be managed through lifestyle and appropriate risk factors, and the earlier we get into those habits, the longer and healthier we will age. That is the message that I try and instill in patients all the time. It's a hard one, but we try.
Understood. Okay, when we think about the top 3 things, if we could leave the audience with 3 things that they really need to work on. I know for me, I think it's probably smoking. I think there's no safe level of smoking, and the single thing that ages your arteries in the concept of aging is smoking. Like, it has a direct impact on your endothelium. And I oftentimes make an analogy to smoking as going to Home Depot and buying a hose, right? When you buy a garden hose, it's nice and it's pliable and you can move it and water shoots out of it perfectly. And then, you leave it out in the elements and calcium gets on it and then it gets like hardly bendable and, you might have a clog in it. So I think when we're looking at these 3 items, there's diet, there's exercise, and we talked a little bit about that. But what you eat, how much you eat, and how the actions that you take directly impact your blood pressure and your cholesterol, which are really those core drivers of prevention as well as aging that we talked about. And I think what you eat most days is probably more important than what you eat on special occasions. And so in both medicine and in underwriting, I think good habits just improve health and they also change risk outcomes. What are your thoughts?
First of all, I agree with you 100% on the smoking thing, and it's a great analogy. Yeah, smoking is the number one for me, but I would say that exercise is the most under talked about, and it's the reason why most of our society is not meeting minimum exercise targets. Fitness is a biomarker that we don't often talk about. We won't get into the details, but I want to focus on exercise. And the 3 things that I would leave patients with exercise is that, 1, think about exercise as it is a medicine. It's medical exercise, just like diet could be. There's a dose, there's a frequency, there's an intensity, and we need to prescribe it that way. 2nd, start small. So I start my patients off with 10 minutes a day, not 11, not 9. And if it's 10 minutes too much, it goes to 5. It's a winnable amount. And then the 3rd thing, and something I've been working on for a very long time, is showing people what impact even 10 minutes of exercise a day can have on their longevity, on their heart attack risk, on their stroke risk, cancer risk, et cetera, et cetera. And it is shocking. People's mouths drop. You mean I can get that much health benefits out of doing so little?
Well, we see that. I mean, we see that with some exercises that people do. I mean, if we look at VO2 max, for example, that's like a really good indicator. The higher your score, the lower your risk of cardiac disease. It's showing how your body's actually using that oxygen, both in your muscles, in your heart, and your lungs. So I think that, there's many benefits to exercise. Now, I know you're working on some things, and I'm wondering if you could share with the audience what you're kind of cooking in the kitchen.
Yeah, no, that's great. Thank you for that. So my heart fitness touches on a lot of what we've talked about today. It's really giving visibility to lifestyle prevention. And it actually does translate every weekly dose of exercise or daily dose of exercise into what it is doing to their health outcomes, their longevity, their, as I said, cancer risk, heart attack risk, mental wellness, even healthcare expenditures and productivity. We've been able to map that out. And so we have a platform that is able to help people through and get them to exercise targets. Our focus is really solving the physical inactivity problem of society. How do we get the 70% or 50% of people who are not meeting minimum exercise targets to their exercise targets so that we are all going to age healthier? So thank you. We've tested and developed this in thousands of patients, 3.5 years of added life expectancy.
Oh, wow, that's incredible.
For sedentary populations. So we see a lot of value that we can offer both to the insurance world and to the workplace world and to the healthcare world. And we're ready for business.
And I imagine that, one of the hardest things when you're looking at your patients is getting that motivation. And so if you can have a more prescriptive way of getting them engaged and having the ability to get them into that state of exercise and doing small things more consistently, I think that pays probably significantly.
And the visibility. We talked a lot about the invisibility and silence of
cardiac
blockages.
disease.
If they can see what that looks like, it's been one of the most powerful drivers of change. So we're very excited about it.
And I think honestly, the best cardiac story is the one that's probably never told.
Yes, you're right. Very well said.
Dr. Alter, where can we find a little bit more about your app?
You can scan the QR code in front of you and it'll take you right to our website.
Excellent. Well, thank you so much for joining us. I hope the audience found this really useful. I know I always enjoy speaking to you, so thank you again.
Thank you. It's been great. Thanks so much.
Today's discussion made one thing clear. Heart disease may be common, but it can be managed, and it is often preventable. By combining medical insight with practical tools, there is a real opportunity to improve outcomes. Thank you to our guests for sharing their expertise, and to you for being part of this important conversation. Join us on our next Life Forward, where we will be joined by Rohit Thomas, President and CEO of BMO Insurance. Definitely one you won't want to miss.